Good morning, sir.
Good morning.
Good morning, dear audience. Today I'm going to be presenting a case on cerebrovascular accident or stroke. So, presenting complaint is right upper limb weakness for 1 day, right lower limb weakness for 1 day, and slurring of speech for 1 day. 68-year-old male from Kochi presented complaining of weakness of his right upper limb since yesterday morning, which was acute in onset. He also noticed that his right lower limb was weak and patient could not stand up and walk without support. He also had slurred speech since waking up and his family members could not understand what he was speaking. No history of headache, seizures, vision loss or hearing
Okay.
loss. Past history is a known case of systemic hypertension since 5 years, now on amlodipine. No history of dyslipidemia, coronary artery disease, or type 2 diabetes mellitus. General examination, pulse is 87 per minute, regular rhythm. Blood pressure is 160/96 mmHg. Respiratory rate is 18 per minute. Saturation is 98% and temperature is afebrile.
Okay.
Pallor, icterus, cyanosis, clubbing, edema, and lymphadenopathy were all absent.
Okay. Okay, you can continue. You can continue. I just move it. Okay. So you are in this slide. Past history. Okay. So
Yes, and the pallor, icterus, cyanosis, clubbing, edema, and lymphadenopathy all were absent.
okay.
Now coming to the systemic examination of the central nervous system. First, we tested for higher mental functions. Person is right-handed.
So is it important right-handedness in neurology case?
Yes, sir. The handedness will show us which hemisphere of the person is dominant. In this case, it's the left hemisphere
Okay.
of the
So
brain.
right-handed people, most of them will have left dominance.
Dominance.
Okay.
Yes, sir.
Now instead of this can be added in a normal MBBS case, this has to be there, but it is always better to document the GCS.
GCS. Yes, sir.
So for normal MBBS case, that may not be required, but when we are treating a patient, GCS is most important because you can monitor the patient whether the patient is improving, deteriorating. Because GCS is all numbers. Like normal GCS is 15. Okay, from that if it is deteriorating to 8, that means patient is in bad state. Okay,
Yes,
so it
sir.
is always better to document GCS. Since it is full GCS, full consciousness, orientation, movement of eye, everything is normal, GCS may be 15. Okay.
Intelligence and memory are intact,
Okay.
but speech of the person was difficult to understand.
So what is the importance of intelligence in a patient when you are examining neurology system?
So it will tell if say anything acute after the.
Not because of that, because you are going to examine the patient. As an MBBS student, you are going to examine the patient. So there are a lot of tests which a normal person will just understand. Okay, but if the intelligence is low or if he is not able to understand, you have to modify your examination methods. Okay, because you may be asking to calculate like 1 plus 1, 2 plus 2, like that you will be asking the patient to do it. If the intelligence and education is not good, you will not be able to do all these things. You will have to just ask the patient to count fingers like that.
Yes,
Okay,
sir.
so you have to slightly modify according to the patient's intelligence and education. So that is very important.
Yes, sir. Speech was also difficult to understand.
Okay, so what type of speech disorder he is having now? That is very important. When you discuss about speech disorder, there are two important types of speech disorder. What are the two important types?
So dysphasia.
Okay, one is dysphasia. Dysphasia. Okay, phasia is that means disordered phasia. Okay, other one is
Aphasia.
okay. That all comes in dysphasia.
So
Other one dysarthria. Okay, so dysarthria and dysphasia. Okay, so if you divide this to dysphasia and dysarthria, where is a lesion in dysphasia? Where is a lesion in dysarthria?
So dysarthria, most likely it's a cerebellar lesion.
Okay, dysarthria means it's a peripheral apparatus problem. Like it can be cerebellum, it can be your facial nerve, it can be your like tongue involvement. Okay, so brainstem and cerebellum that controls your speech apparatuses like your larynx, pharynx, tongue, lips. All these things are controlled by brainstem and cerebellum. Everything is coordinated by cerebellum. So that produces dysarthria, whereas phasia is again divided into motor and
sensory.
motor and sensory. Okay, motor dysphasia means
Broca's.
Broca's aphasia or dysphasia.
Yes, sir.
That means patient is not able to
Express
express
the
he is understanding everything,
but
he
he's
can
not
write, but he is not able to talk.
talk.
Okay, whereas sensory aphasia means
So he will not understand
he will not
what is being
understand.
spoken, and he'll be giving an answer completely unrelated
Okay.
to what is
So
happening.
that is the division of speech. Okay, speech abnormalities. So basically they are divided into dysphasia and dysarthria. Dysarthria basically involves the peripheral speech apparatus that controlled by brainstem and cerebellum. So the lesions there can produce dysarthria, whereas dysphasia is basically produced by cortical lesion that is again divided into motor and sensory, and repetitive. So many other things are there, but for an MBBS student it is motor and sensory. Okay.
Now coming to the cranial nerve examination.
Okay.
All olfactory nerve was intact. Optic nerve examination was intact. Oculomotor trochlear abducens nerve examination was intact. Trigeminal nerve intact. Facial nerve, puffing of cheek and wrinkling of forehead was absent on the right, and deviation of angle of mouth.
Okay. So one sign alone is enough to know that this patient is having facial nerve weakness. Deviation of angle of mouth towards the left side. That means where is the lesion?
Is on the right side, because
Okay.
the
So
muscles on the right are
right
not
side is weak, so the mouth is deviated to left side. Okay.
Yes, sir.
So you have written that wrinkles of forehead is absent on the right side. Is it correlating with your finding? See,
sir,
puffing of the cheek and wrinkling of the forehead absent on the right side, and deviation of mouth towards the left side. So wrinkling will be absent in which type of lesions? LMN or UMN?
in element mode.
LMN.
Yes,
So if you are thinking about LMN lesion, then that is correct. If you are thinking about UMN, then you have to double check it, because most of the time wrinkling of the forehead is absent, means it is a LMN type of facial weakness. Whereas in stroke, mostly it is UMN type of weakness, and upper part will be relatively spared. So wrinkling may not be absent, it can be diminished. Okay, because 50% of the nerve supply is from opposite side, 50% from the same side. So comparing to the opposite side, it is reduced. Okay, but complete absent means it has to be very severe type of weakness. Okay,
only in LMN.
Okay, so LMN is a classical finding, but sometimes you can get it because the other nerve, the lesion may be very intense lesion.
Yes, sir. Vestibulocochlear nerve was intact. Glossopharyngeal and vagus nerve was intact, because there was no he didn't complain of any regurgitation.
So in emergency room, this is one of the important nerves. Okay, other nerves are like your seventh cranial, all are important for a examination purpose, MBBS examination purpose. But in emergency room, glossopharyngeal and vagus nerves are very important, because if the patient is having difficulty in swallowing, okay, and regurgitation is there is a high chance of aspiration and aspiration pneumonia. So in that type of patients, we have to put a rice tube. So that nerve is very important in emergency room, but rest all nerves are important. I am not telling they are not important, but in emergency room, this is the most important nerve, and for MBBS examination, facial nerve is the most important exam. Okay.
Yes, sir. So now, looking at motor system, bulk was measured in all the limbs, both in both upper limbs, in the mid-arm and mid-forearm.
Okay. So normally, when you are taking bulk, it has to be from same distance from the bony point. Okay, that's all.
Yes,
Okay.
But the right-sided upper and lower limb had increased tone on examination.
Okay. So what is the basic difference between tone and so you have hypertonia and hypotonia? No? In hypertonia itself, there are two types of hypertonia. What are the two types of hypertonia?
Spasticity and rigidity.
Spasticity and rigidity. Okay. So what is the basic difference between spasticity and rigidity?
Spasticity is more common in pyramidal lesions.
Okay.
And rigidity is more common in extrapyramidal lesions.
Okay. What is the basic difference?
One is velocity dependent, other is velocity independent.
Okay. So if you increase the speed, the tone will increase. Third one? Third one is most important. See, the spasticity is like this. So this is your limb. You try to extend. Okay. So if the tone is increased only for one group of muscles, either extensors or flexors, it is mostly hypertonia. If it is more for both, both sides, okay, then it is rigidity. Okay, so that is a third important difference. Okay, and spasticity is more in favor of UMN type of lesion, that is pyramidal tract lesion. Rigidity is more in favor of extrapyramidal lesion. Okay.
So even power was 4 out of 5 only in both right upper and lower limb, but a deep tendon reflex in the right side were all grade 3. There was hyperreflexia.
Grade 3.
Yes, sir.
Hyper or okay. Grade 3 is there. Okay. So on the right side. Okay. So right side weakness and it is increased now.
The
Okay.
reflexes.
Okay.
So that's very characteristic of
UMN type of lesion. Okay. So reflexes are more in UMN type of lesion. Reflexes are reduced or diminished or absent in LMN type of lesion. Okay. But what happens in acute neuronal shock? Neuronal shock means you develop shock in half an hour back. Okay. Now if you examine, it will be completely absent. That is neuronal shock. In that condition, you have all loss of reflex. Okay. But after some time, it will increase. The tone and reflexes will increase. Okay.
Yes, sir. Sensory system examination, touch, such as the touch, pain, temperature, position sense, and vibration sense were all intact. So sensory system has not been affected in this patient. Cerebellar signs, none of them were positive.
Okay. What is the power of that group of muscles? That side, right side? Power.
Yes, sir. 4
4,
out of
4. Okay. If it is less than 3, you cannot test all these things. Okay.
Yes, sir.
That means already power is less. So patient will not be able to do all these tests for cerebellum. Okay.
It will be different.
Okay. So what are the signs of cerebellar lesion?
So one, dysdiadochokinesia.
Okay. Patient will not be able to do the alternative movement like this. Then
Yes, sir. So then patient will like the finger nose
nose test. Okay. Then finger nose test.
Yes,
Okay.
sir. Walking in one straight line.
Okay. Tandem walking.
Tandem walking test.
Okay. So these are the signs of cerebellar sign. Okay.
And no signs of meningeal irritation.
Okay. Kernig sign, Rudzinski sign, all these things are absent. Okay.
Helping us to rule out that it was any sort of hemorrhagic.
Okay. So subarachnoid hemorrhage. Meningitis can produce meningeal signs, and subarachnoid hemorrhage also can produce neck stiffness. Okay.
Yes, sir.
Okay. So what is your diagnosis?
So it's a 61-year-old male with right-sided hemiparesis.
So your diagnosis is right-sided hemiparesis.
Yes, sir.
Hemiparesis. Okay, that is your first diagnosis. Now, where will you localize the lesion?
So we need to first check the internal capsule and each area of the internal capsule or the cortex.
Okay, so in this case, where will you suspect? This is your cortical fibers. Okay, so right-sided cortical fibers are coming like this from the cortex, precentral gyrus. This is your internal capsule. So where is the lesion? Lesion is here or here now.
So most probably it should be cortical because internal capsule would have produced hemiplegia.
Okay, so if it is internal capsule lesion, it will produce intense lesion. That means all fibers will be involved. It will be dense lesion. So if it is here, only few fibers are involved. So opposite side patient can have weakness. Where the internal pyramidal tract crosses to opposite side?
So at the medulla and the
lower medulla it crosses to opposite side. Okay, so this patient will have lesion on the right cortical area. So that patient is having left-sided hemiparesis. Facial nerve is also involved. UMN type of facial nerve. Okay, so right cortical lesion. Sorry, right hemiparesis means where is the lesion?
It's right in the left-sided.
Okay, right hemiparesis means left cortical area, cortex. Okay, so which artery is involved here?
Most probably middle cerebral MCA.
So MCA territory lesion. So now MCA territory lesion. What type of lesion it is? Is it embolism? Is it hemorrhagic? Is it ischemic?
So it's ischemic because an embolic one would have produced something while the patient was doing some sort of activity and it would have been like during the day and immediate, but this was on waking up, so the process would have begun pretty in the night.
So this is MCA territory infarct. So MCA territory infarct will be something like this. There will be some small lesion here. Due to some rupturing of the lesion, there will be aggregation of platelet and fibrin products like this. Slowly it will block the artery. Okay. So it is mostly ischemic lesion. Okay. What may be the etiology? So you have made your diagnosis, where is you localized and which artery is involved, you have written, and now you are telling it is ischemic. Okay, that is a pathology behind that. Okay, now what is the cause for this?
So the patient is a known case of systemic hypertension.
So hypertension is one risk factor. Okay, then
another risk factor is dyslipidemia, but patient has not been diagnosed.
So dyslipidemia, okay, but dyslipidemia can be there. Is he diabetic?
No, sir, he was
He's
not.
not. So these are the risk factors. Okay. Now, why do the patient develop this type of problem? So we have already explained that there will be some lesion in the artery. That lesion will contain what are things? Platelets, fibrin, then cholesterol. So three things will be there. Okay. So slowly this will propagate and block the artery.
Yes.
Okay. Now you understood this. Okay. Now what is the first step you are going to do in this patient? Patient came with acute stroke-like symptom to your emergency room. Okay. You understood where is the lesion. How do you made a diagnosis? You understood. Now what is the treatment you are going to do it? Do for the patient.
So treatment first in line of management. Immediately we can ask for a CBC.
Okay.
And then we can go for an MRI or CT scan to rule out bleed, and an MRI scan to
So
know
first thing when the patient come, you always take care of blood sugar.
blood sugar.
Okay. Why blood sugar?
To know if it was an episode of
Hypoglycemia. Hypoglycemia is the most common finding in emergency room, which can mimic a stroke. Okay, so you are doing a blood sugar. Then you are going for a. So meanwhile you are take care patient's airway, breathing, circulation. Okay, why airway, breathing, circulation? Because this patient can have difficulty in breathing because of all these secretions can pool in the oral cavity, and they can have breathing difficulty. So you have to aspirate everything. Circulation is this patient either can have hypertension or hypotension, but here the patient is having no hypertension or hypotension. Okay, because if there is BP is very high,
if the BP is very high, it could have caused a
okay,
IC bleed.
there is a chance of IC bleed. But remember one important thing, that one important thing is ischemic penumbra. Okay, what is ischemic penumbra?
So ischemic penumbra is the area surrounding the infarct that can be saved.
So infarcted area is a core area. So this is the core area. Okay. So this is supplied by one artery. Okay. This is supplied one artery that is blocked. Okay. And the surrounding area, that is penumbra, this may be supplied by the collaterals or some other blood vessels. Okay. So when this core area is blocked or core area is not getting blood, what body will try to do?
Will try to increase the
systemic BP. So systemic BP will be increased in response that the brain cells are not getting blood. So that in that response, systemic BP will be increased. Okay. So that this peripheral circulation can, or sorry, this collaterals can perfuse this area well. Okay. Now suppose this patient's BP is 180 by 100. What you will do?
So we would just try to bring down the BP, not very low, but it's actually needed to serve.
So you don't want to reduce it because of this ischemic penumbra problem. If you try to reduce it, this perfusion will come down, even the penumbra will die. Okay, so you never try to reduce BP drastically if it is something like this. If it is more than 220 by 110 and all, you may try to reduce, but that too in 24 hours. Okay, yes. No, not more less than 24 hours. So you need to reduce it only slowly. But unfortunately, if you see a bleed, then you have to reduce it fast. Okay, that's all. Okay, so that is about ischemic penumbra and BP. So next thing, so you take care is blood sugar, you take care airway, breathing, circulation. Third important thing will be
so the
you go for CT scan. Okay, why CT scan?
So CT scan will help us to see if there is any intracranial bleed.
Okay, CT scan will help you to rule out hemorrhage. Okay, that is the most important thing. CT scan will mainly help you to okay. Okay, so CT scan will help you to rule out the bleed. Okay, so if there is no bleed in the CT scan,
So then MRI also will help us to show us.
MRI is not a routine investigation in any stroke. Okay, if you are not going to thrombolize the patient, you have time, because sometimes patient come after 8 hours, 9 hours, like that. So no need to thrombolize. You can wait. In that case, you want to know where is the artery blocked, what type of block it is, whether you can do some procedure or not. Then only MRI and MR angiogram is required. Otherwise, CT alone is enough. Once CT is done and you are ruling out hemorrhagic stroke, then what do you do?
So we can start treatment for the patient.
What are the treatment options?
So aspirin and
So
clopidogrel.
you give aspirin 300 milligram, clopidogrel, then
We can
statin.
statins.
So three important drugs can be given from emergency room itself, or even if you are working in a peripheral center, you can give it.
Yes,
Then if the patient comes less than 4.5 hours, that is golden hours.
Golden hours. So we can plan stent placement.
No, before that you can go for TPA, tissue plasminogen activator. Okay, TPA. Okay. Now if the TPA can be given in acute stroke to dissolve the clot. If the patient comes after 4.5 hours or 6 hours, you know that it is a ischemic stroke. What else you can give to prevent the propagation of thrombus? You cannot lyse the thrombus after that. You have to, like you told, you have to take the patient for procedure. Okay. What other drug which can prevent the propagation of thrombus? That is heparin. Okay. If you are not able to give TPA and the time is over, then you can go for heparin. That can prevent the propagation of thrombus. At same time, it can even prevent the deep vein thrombosis, because many patients who are admitted in ICU stroke, they will not be able to move around.
Static.
So we have to give low molecular weight heparin or heparin to prevent DVT. Okay. What other things you take care in the patient? One is you have to put the rail tube if the patient is unable to swallow. Second one, if the patient is not able to move, you have to put a renal catheter, urinary catheter. Third thing is physiotherapy. So physiotherapy has got most important treatment after the stroke. Yes. Okay, how do physiotherapy help in patients who is having stroke?
So because many of the times their limbs will be weak, and this will help to regain maybe not full but near complete motor.
So one is improve the power. Second thing is it decreases the contractions. So contractions will be there after some times. If you don't do the physiotherapy, the limb will be contracted. Third one, in brain there is another phenomenon you can see here. Suppose this part is dead, will neurons regrow?
No, sir.
Neurons will never regrow. Okay, but if you are, suppose this is an area which controls your thumb, small area, there are other surrounding cells also can be there used in controlling the thumb. Yes. Okay, but if this area is not working and you are doing physiotherapy for your thumb, the surrounding cells can grow up or they can enlarge. The numbers will not increase, they will become larger and they can take up some function of the thumb. Okay, so in that sense, physiotherapy slowly improves the strength of the patient, but the dead area will never grow because there is no regeneration in neurons. Okay, so that is physiotherapy. So ultimately, what we have discussed is case of stroke who came with ischemic stroke, and we can treat the patient with tissue plasminogen activator. Okay, so what is the side effect of tissue plasminogen activator?
So if it was older ones like streptokinase, many of them can have hypersensitivity.
So immediate reaction will be hypotension and some itching reaction. But around 15% of the patients can have hemorrhagic transformation of stroke, especially when the BP is very high or if there is a large infarct. Like that, patient can develop some amount of bleeding into the stroke. So we have to be very careful when we are thrombolizing. We have to select the patient according to criteria. There are some criteria like age, size of the thrombus, duration of the thrombus, like that. Some criteria are there. And BP is also very important. BP has to be reduced but not less than 185 systolic. So some criteria are there that has to be fulfilled. Okay. Okay. Thank you.
Sir. Thank you so much, sir.